a stretch.
Just up to the six. And then round.
Oh, that's lovely.
And good.
Can we have a little tree as well? Swaying with the breeze. Marvellous. And have a sit down.
You know what's interesting about prediction? I was thinking about this about patient. It's like what we're predicting about the patient. Like what we expect them to be doing.
Absolutely.
Which is sort of because I've got this lady I spoke to I had a telephone with a new patient, and she is about to have a coxygectomy or something, and she's very young, sits on a chair, on a wheelchair all the time. And so she came in to see me, and then I said, "Oh, will you be able to just, what can you do?" And she got up and walked around the room and sat in bed and got up to bed, and I think my prediction of her before on my I mean, I don't really know telephone clubs anyway, but I suppose that sort of fed into it. I don't know, did that not make her feed into her pain, but feed into what I thought she could do?
It will. You know yourself that those patients that come into a room, and if you're in a total, if you've had a good day, you haven't had any arguments with your family, you're well fed, you're well rested, you're totally zen and happy, and they come into your space and you absorb that energy, they go out with their feeling much better. Nothing to do with what we physically done to them, just from having a good conversation, a good chat, calm down. So our predictions absolutely will do that. In parenting, they talk about as parents, our kids borrow our nervous system, borrow our regulation. So when they're going absolutely mad, I'm in the toddler years, I'm reading about this a lot, and when they're having a meltdown, we give them our nervous system, we teach them to regulate, we give them ourselves to regulate, we give them cuddles, and they calm down. So about our predictions and how we're coping with their system. Absolutely. It's a huge input. We'll go on to it later. Okay, bladder pain syndrome. Hit the ground running. We've already got pain nails. That's why I give it to you beforehand, else we'll be here for 4 hours. BPS. We're going to go through the what, the who, the how, and the why. First is the what. What is it? Is it interstitial cystitis? No! That's what we used to call it. It was called interstitial cystitis because it was thought that it was a cystitis, an inflammation of the cyst, the urethra, interstitium, kind of mid-layers of the interstitium. It's actually a heterogeneous spectrum disorder. Lots of different colours and shapes. So no two bladder pain syndrome patients are the same. And that's the challenge, is that it's a huge umbrella term. It is defined as pelvic pain, pressure or discomfort that lasts for more than 6 weeks in the UK, or months, depending where you are in the world. It worsens with bladder filling, that pain, and it eases when they have a wee. It gives them a persistent urge or an increased frequency. They need to go to the toilet more. With or without identified bladder or urethral infection. So the last bit doesn't matter. So it's 3 things. Pain, urge, frequency, and pain gets worse with filling and easier with emptying. So it's basically pelvic pain related to bladder function. Okay. There's lots of things about words. I'm a pedant for words for lots of different reasons. One, within a research context, if we all use the same words, then we know what we're talking about, and you're going to see why this causes massive error in about 3 hours. The term BPS is increasingly recommended, with IC being reserved for those who have Hunner's lesions, which are a bit like ulcers in your bladder. That's what MELD has come to, because there are multiple national and international guidelines for it. We call it bladder pain syndrome, BPS, biopsychosocial, easy to remember. Americans call it painful bladder syndrome because they like being different. Our BMA guidelines, best practice, the most up-to-date, the AUA came out yesterday, annoyingly, so I haven't updated my slides, but I saw it at 9:30 last night. I got an email that Clemens has published the American ones. But at the moment, the UK, in 2018, we reversed our decision. We were having been lots of different things. We went to calling it one thing, a bladder pain syndrome, and then the BMA went, oh, we want to keep IC as a little subgroup. So they've snuck IC in as patients with all of the things of BPS, so pain, frequency, urgency, gets worse when they fill, and eases when they empty, longer than 6 weeks duration. But IC is when they have inflammatory changes in the bladder, which is Hunner's lesions or glomulations, which is something we'll see in a minute. Realistically, how many patients do you get with IC diagnosed and sent to you? How many do you see?
I get quite a lot.
You're in London.
I tend to go to urogyne nurses more than
Yeah? What about urgency frequency syndrome? No, I used to get loads of those. I had an old school guy. Levator ani syndrome? Yeah. Urgency. But it gets a bit sore. It hurts when I hold. What about your dyspareunia patients? How many of those have got any bladder-related issues? Your chronic prostatitis patients, if you see in males, chronic urological pelvic pain is BPS. Your vulvodynia patients that are also a little bit wound, and you're like, she's just really wound, I need to relax everything, and a vulvodynia will get better. But she's also rushing to the toilet. Vaginismus patients. She's generally highly stung. It's hurting to have sex. It only comes on those times. But she's not incontinent, but she's having IBS and urgency. She goes to the toilet 50 times a day, or 18 times a day. Chronic urological pelvic pain, which is BPS in men. Complex pelvic pain. How many of you seen complex pelvic pain patients? Yeah. And any involvement, painful bladder is the Americans, and climacterium penile dysesthesias, we don't see them so often anymore. What I'm trying to say is that when you take the diagnostic criteria, you find that actually you are seeing many, many more patients with bladder pain syndrome that would come under this umbrella than you think. So people come on this course thinking it's a niche course, and hopefully go away thinking this is all of my patients with pain who have some form of visceral involvement. Everything that I'm talking about this weekend is relevant to any form of visceral pain. The evidence and the research I haven't put in from IBS, from endometriosis, adenomyosis, that kind of stuff, but it's all showing the same thing at the moment. So the way that we're going to address it is this is a way of treating visceral pelvic pain. Hopefully you'll go back to your clinics and any pain patient, any form of pain patient that comes through, if they have any form of urgency, you're going to go, BPS, and treat them with that. Doesn't mean you have to diagnose them, but have it in the back of your mind. So we call it bladder pain syndrome. It's a diagnosis of exclusion. There isn't a test. You can't do a sample, you can't do a blood test. 68% of women are diagnosed wrongly, so this was a retrospective look at women that had come into a clinic. Found that nearly 70% that had the diagnostic criteria were wrongly diagnosed with vulvodynia, vaginismus, dyspareunia. They're your overactive bladders that have got low back pain. It's always worse when they need to wee. It gets really intense, and then they have a wee and their back eases up a little bit, but the back always hurts. I've always had low back pain. I've always had pelvic pain. This very study was huge. 140,000 American households were screened, and they found 37,000 households with BPS diagnostic criteria positive people. Of those people, 50% had no diagnosis whatsoever, and of the 50% that had a diagnosis, around about 16,000 people, women and men, again, only 30% were correctly diagnosed. So it's really, really poorly understood. When they are diagnosed, this is what this is a review of all the diagnostic criteria, but the European EAU, we should still be having a history, physical examination, urinalysis, urine culture, cytology, symptom scores, diagnostic hydrodistension, we'll come on to that, cystoscopy and bladder biopsy. Which one do you get covered by, Samaya?
Gulf countries, so I'm not sure.
Sorry, which one?
Gulf countries.
Have you got a guidance document for this? So would you look to, where would you generally go to? Would it be American guidance or
European?
European. Make my life easier, it sounds easy, because I know my European inside out. As I said, the AUA has just changed, the American ones have just changed. Most of this doesn't get done with our patients, and I'm going to show you what they actually do need to do. They do need to do a 2-day bladder diary. They say 3, but it does need to be 2 days diagnostically. They're meant to do a hydrodistension, which is where they put water in, blow up the bladder. It's really silly. Does this hurt when I rub it? Yeah, it hurts. Okay. Yeah, you've got a problem. Hydrodistension, they used to stick in potassium, which was literally putting salt in the wound. And if they had a positive result from that, which meant that it really, really hurt, and it made it really reduce the volume, reduce compliance for weeks and weeks, if not months after, sent into massive flares. Yes, you've definitely got a problem with your bladder, is what they were diagnosed. So they don't do potassium anymore. That's been not outlawed, but it's not done. But they still do those hydrodistensions. They kind of feel like, oh, we'll just really, really stretch and blow it up so it bleeds, and then it can heal. But what it tends to do is just cause lots of flaring of the unhappy bladder. It is optional in those guidance. In the UK, we don't do this anymore, but it is in the guidance that could be, so you might see it coming through. They do two things. They do the biopsy, which is in this line, and they do cystoscopy, which is along the top. So cystoscopy, they look in the bladder. When they look, they're looking for bladder ulcers, like you get on your tongue, exactly the same. And you can have them, you can not have a cystoscopy, have it be normal, have Hannah's lesions, which are these big ulcers, or have glomulations, which are kind of halfway there. I'll show you them in a minute. And then on a biopsy, it can not be done, it can be normal, it can be inconclusive, or it can be positive. And positive means positive for inflammatory infiltrates like mast cells. If I said mastocytosis to you, does it mean anything? Okay, mast cells are part of our inflammatory group that are responding to fighting what's going on, so part of our white cells. They come into an area, they try and solve the situation, but in some people we have a condition, mastocytosis, where they go a bit crazy. It can create scarring, not adhesions, but scarring, kind of a really unhappy, scarred bladder that has very low compliance. If you do get anyone through with this kind of criteria, which nobody in the UK really is using at the moment, the only one we don't treat is 3C, because this is someone with loads of unhappy lesions, but that's not really the issue. It's the issue is they've got mastocytosis. I'm pretty sure, I've no idea. So they've got very unhappy, a bladder that has poor compliance. We will treat them from a life point of view, get them better, get them hurting a bit less, but their bladder compliance isn't ever going to improve really. This is a normal bladder. Come on. Oh, it's not going to work. If I make this, just get on the internet and it won't work. If you want to see what they look like, it makes a big difference. This is what a normal bladder looks like. So you've got lots of vessels and quite a white background. This is glomulation. Right, fine. So I'm going to do it. We'll do it on here. So in ulcers, that's a bit more of a Hannah's lesion. Hannah's lesion is where lots of the blood cells come together and it's much more of a fixed point. Lovely. In a glomulation, it's more, you get petechial bleeding. That's an ulcer. Petechial bleeding is a bit like, think of it like eczema skin. So it's just really sore and raw inside and it just kind of showers down. That's an ulcer. It's quite a focused point. Lots of blood vessels go into it. It will bleed if they prod it. What they're doing is they filled up the bladder with fluid and then they're prodding it from outside, which is where you can see it's. As hydrodistension progresses, they appear. Funny that, if you blow up, the broken bits of skin start to bleed. Petechial bleeding can be really nasty. initial final, they've made it, their bladder really angry. It's not very nice.
Did you get that from recurrent infections? Is that why you get bladder?
Yes, you can do. Yes, this is the video I use. This is for taking bleeding. So these are glomulations, but it's just eczema skin, thin eczema skin, breakages in the lining. But that's someone that would have rust-coloured urine. They haven't got cancer, but they've got nasty glomulations. And there's a better one for this.
So they always have complex cardio
While they're bleeding.
So, or that should be like after they've done their distension.
No, it could be all the time. Think about again, eczema sometimes just moving cracks the skin. It doesn't have to be that you're itching it up or putting pressure on it. So it's an the skin. Oh, there's the scope. Go down the scope. Is this going to show you the conversation? Okay, the one I've got is much better than that. As you can see it. Doesn't exist. Okay, fine.
Some of the ketamine bladder habits discussed it really like that.
Yeah.
We discussed it a lot. We didn't I don't think it referred to me, but we discussed it in the team.
Hannah's ketamine bladders, mastocytosis, very, very collagen-rich, scarred, burned. You know, think about loads of scar tissue in your bladder so it cannot stretch.
It's
really
not
unhealthy.
reversing, is it? It's what you've got it, you've got it,
Yeah.
What was that, sorry?
Ketamine.
I just wish that all these students knew that. Oh, okay.
Yeah,
So-
so that we drop it.
Yeah.
But
They all
don't
take it
drink
uni
it.
now, don't they?
And
The
it's
problem is, it's not
Yeah.
terrible for you,
No.
but we had a big problem in Wales with it, that kids take them, and this is what they do, they burn them out. And I've gone to endless conferences where they talk about different ways of burning the lesions out. Anyway, so they go into lots of depth with it. In Wales, we had a big problem with ketamine in the rural areas. Lots of kids suddenly, there was a lot of ketamine about. The problem is that it makes you sleepy and you go to sleep and you're still, but you're not asleep, you're just resting. So it sits in your bladder. And the poison, the chemicals, can sit in your bladder for a long period of time and you're numb to everything. So by the time that you actually wee, a day later, you've had an massive expansion, but you've also had a high level of really burning, horrible chemicals inside your bladder for a long time. So the amount of scarring on the bladder lining depends on how long you've been under and not weeing. So the best thing to do for someone on ketamine is to get them to go to the toilet. You know, to get them to keep drinking and go to the toilet. And if they're not able to catheterise them, that's what they do in hospital. They put loads of fluids in and catheterise so that it doesn't scar the bladder. Yeah. Oh, it's pretty miserable. Okay, well, this lovely, perfect Hun's lesion, when you look at it, it pulsatile bleeds, but there's a lot more blood from a Hun's lesion. And this is the moon. The one thing to know about these two things is that we found Hun's lesions in asymptomatic people and glomulations in asymptomatic people. So we don't think they're actually a problem in bladder cancer. So as much as they are a whole diagnostic criteria less, again, we remain to be convinced that they're actually causing pain problems. Much like me, so I spent years on lots of different medications for my heart, and I used to have loads of, I normally have got one or two ulcers around my tongue. I haven't at the moment, I've got a couple of pit patches and sore. You can live with them without knowing. So it's the same in your bladder, they don't necessarily cause an issue. But doctors like a thing to look at, like, ooh. There's also the potential, because we're still finishing off what, for embedded infections. So London are very, very aware of bladder issues because they've had Maloney's clinic, Harley Street, Whittington, that kind of stuff, which is brilliant. This is a much longer conversation. I've got a whole course on it that you guys get 50% off easy. Actually, to be fair, if you go back in the group far enough, you'll find it for free because I did it as a webinar to all of the group members. What life is very short. I'm not on this planet to make lots of money. I really should be a better businesswoman, but I'm not. So what I tend to do is give all of my education to my team. So my tribe, there's about 650 people now. I did a webinar this week. I can't remember what it was on, diaries and stuff. So anything that I do before I put it up behind the paywall, I give to you guys. You're in the tribe now. So you can go back through all the videos over time with your teams and watch any education that you want. So do that. I mean, it's only up for about 50 quid anyway, and you get 50% off. But if you want to know about embedded infections, go back through the Facebook group and you'll find 2 hours on it. Right, we're going to talk about who gets it. Before we talk about who gets it, let's do like a Mexican wave. Starting with Lily. Ready, steady, go! Oh, come on, wave. We'll go from this side of the room to that side of the room. Mexican wave. And then back all the way. Yeah, good. Okay, the who. Women during their childbearing years, 20 to 40, when we are hormone active. Tends to be more women, and unfortunately it tends to be Jews. So there's a subset, I'm pretty sure it's Sephardi, a genetic line which suggests that there is a genetic link. It's only a slight increase amongst Jewish women, but it's particularly noted in that one population compared to anything in the world. The ratio is much greater in women, about 10 to 1-ish, depending on what you look at stats-wise, and we can have anywhere between 0.3 and 30% of the population of the world at any one time having bladder pain syndrome, depending on how you define it. And that's based on old data. I mean, this is 2014, before the new diagnostic criteria came out and cleared everything up. And that's the problem. Because it's wishy-washy, it can be your vaginismus patients involved in your OAB patients with some back pain, or some other, because the pain doesn't have to be between their legs or inside, it can be anywhere around the pelvis that's related to their bladder function. It's very hard to find these people, and it's been very hard to get accurate populations. But if we translate the most conservative estimates, that's around about 890,000 women and 130,000 men in the UK. In the UK, where are they? They're your pelvic pain patients, and your vaginismus patients. Oh, Lydia, still Lydia. The AUA, the last guidance, talked about it being part of a more generalised systemic disorder. And if we're going to treat it, because it is part of a generalised systemic disorder, it's not a bladder issue, it's a potential underlying lots of things issues, we need to know more about it. And that's about phenotyping. Phenotyping means putting people into boxes where everyone in the box is the same in one way. So they're all women. They're all 47-year-old postmenopausal women, early postmenopausal women with no Hannah's ulcers that respond like this. Because the best way that we can get to treat them is to knowing what's wrong with them and try and box them. And there are loads of phenotypes, but they are emerging like smoke on the wind, and it depends what you're looking at. So there are actually different colours in this smoke, but it depends on who you are and what you're looking at, whether or not you see the different colours in the smoke. And that's what happens with phenotypes. So the first phenotype that emerged was the guy called Nickel and Tripp, created the U-point. Has anyone ever heard of the U-point? Yeah, at this point no one has, it's great. I used to be referred people with like, they are U-point T. They have tenderness, that is their problem. So this is a heavily biomedical model. They got tenderness, urinary, is their urinary system the cause? Is it tenderness? Is it mostly psychosocial? Is it mostly organ specific? Is it mostly neurological? Or is it an infection? And the good thing is you can put Hannah into that system and she comes out as, yes, she's got everything, but definitely no infection. Because you can look it up and put data in online. I don't know how they can tell she's not got an embedded infection from putting her symptoms into a box online. But that's me. So I'm not a fan of the U-point. Big fan of Nickel in general. He's doing some really cool stuff at the moment. I see maybe a subgroup of BPS, but I think more likely chronic urinary tract infection, embedded infections, is a subgroup. And actually I've got to add to that now because Nickel, 3 weeks ago, I sneakily saw a presentation, a small presentation he gave to some people in Canada at a conference. And the work they're doing at the moment is looking at bladder pain syndrome as an allergy response. So a body response to, like an allergy, I know she's been sniffing, but within the bladder, which is really clever. Then Jason Kutch came out with the widespreadedness of pain. It's a word he's made up, but it's really useful. They found that there is a stark difference between how widespread someone's pain is and their outcome. It predicts their improvement. Who do you think gets better quicker? Yeah. within the pelvis. So they have within the pelvis and without the pelvis, outside the pelvis. People with more of a pain state elsewhere tend not to do so well. And it's quite stark. If you've got mild pain, but it's widespread, your quality of life isn't great. If you've got mild pain and it's focused, your quality of life is much better. If you've got extreme pain and it's widespread, your quality of life is rubbish. So, and if you think about it from a predictive processing point of view, it doesn't matter where you've got pain or what is causing pain, what is instigating a prediction error, you're more likely to have pain, your pain to build everywhere because of our upregulation of our systems. And that's why they don't do hip and knee replacements on anyone with thoracic pain. You know that rule? Orthopedics. They won't do them because it's a massive predictor of it not working. They'll give them loads of injections over years and they'll send physio to sort the thoracic pain out and hope that improves. They might even do some thoracic surgeries. And neck pain actually. I don't think it's an out and out right. Then there's lots of phenotypes within our psychosocials because we know that depression, anxiety, lots of other things have a huge impact on pain that we feel. Not necessarily that it's just making it worse, that they are actual causes of it. Yeah, when I'm ill, whatever ill I am, if I start feeling my chest, if the anxiety kicks in and I don't get it because I've had heart surgery, done lots of really dying, the anxiety will build and then my anxiety will make my chest feel worse. It'll be nothing to do with it, I'll have a cold, but if I don't get on top of it, so I'm acutely aware of the interplay between emotions and pain. Okay, give me 5 quick facts of things that we've talked about. You have to stand up and play whack-a-mole. Anyone play whack-a-mole before? Okay, you've got to think about a fact from the last little bit about what or who gets it. Anything at all. Put your hand in the hair when you want to say it.
Jewish women are more likely to get it.
Whack-a-mole, sit down.
Frequency.
Frequency, sit down.
Oh,
Can't drive us.
Different for any visceral pain.
Brilliant, any visceral pain, sit down.
890,000 to 2 million people.
It's a very good fact, you never know.
Anxiety can increase it.
Sit down.
More women than men.
More women than men, 10 to 1. Sorry, Joe, you can
That's right. Pain reduces when you empty your bowel.
Go, fab. Anything at all.
Like vaginismus patients.
Fab, sit down, good. Okay, so we'll talk about the how now. How do they get it? We've talked about what it is, we've talked about who gets it, this is the how. This is a summary. There is an initial insult to the area. That could be sexual abuse, car accident, an infection, a surgery. From that you get symptoms that feel like an infection but they persist beyond the normal healing time scale of 3 weeks. So we get a change in the error and the prediction update. It doesn't update. That causes central and peripheral sensitization. We get this persisting threat response or error signalling. And due to this, we get a massive change in the inflammatory, neurological, and endocrine systems in the area. And what happens? There's potential for an underlying autoimmune disorder, and there's potential for nerve growth factor. And I'm going to add allergy to that as well, but it's kind of covered by autoimmune. This is a summary. There is also an insufficiency in the glycosaminoglycan layer of the bladder, making urine toxic. So when urine gets through the bladder lining, it hits the nerve cells that are deeper down in the skin of the bladder when it shouldn't normally have got to them, and they go, ah, it burns! Because urine is toxic. So the urine becomes toxic and it irritates the nerves, and the nerves fire loads. They get hugely upregulated, their threshold goes down. So they fire more often. And that causes chronic inflammation, and we get an upregulation of the C5 afferents, which is their threshold goes down. They get upregulated. Maybe there's something to do with Hannah's Welch's, but it's unlikely. Maybe there's some persistent resistant embedded infections. There's definitely pelvic floor muscle dysfunction. We're going to go through all of that a little bit closer.
So if I just ask you, the GAG layer, deficiency, is that the outer layer of the bladder?
No, that's the inner. You can see why in a second. It's a piece of string. Lots and lots and lots and lots of things going on, which is why it's a spectrum disorder. There are patients who have had an infection that was treated poorly. I'm thinking of one that was treated homeopathically when she was 6. and at 17 she came to see me. 18, she just turned 18 actually when she came on my research trial, and we got her symptom free. She didn't have an infection anymore, but she'd had like a massively unhappy bladder. There are other patients that had an infection, it went away, she had some thrush, some sexually related stuff, and then she would flare when emotional stuff happens. She came back in to see me once we've done 9 or 10 weeks of treatments and got her pretty much sorted, because some of them are pretty simple. She couldn't work out what happened. She had one flare related to going to a festival, didn't want to sleep in a tent and be dirty, was really worried about getting an infection, only washing with wet wipes. So she came in, we did some sessions after that to calm down. The next time she came back, she was like, I need you to find my bears, the thing's attacking me. Where are my stresses? I can't work out what my bears are. And I was like, okay, fine, how's life? She went, oh, well, you know, job's, oh, I hate my job. I hate my job. So her physio homework was to write a CD, and she got better. There are peripheral changes and there are central changes. We're going to look at the peripheral ones first, based on a predictive process. So remember, all of the chemical changes we're going to go through are predictive, and they're useful. They only happen because they're useful. If I said active inference at you, we might need to talk about this one a little bit more. Active inference is, actually give it blank, is the process by which something happens and you've got to go, ooh, that's different data. That doesn't fit with my model. Ooh. And what you can do is you can either take it in and try and change something within you to afford for that new data, or you can do something different actively to afford for that new data. So sometimes the system changes how it functions actively to accommodate new data coming in. So some of the processes, it explains why we get chronic inflammation, because it should have a start and an end point, but sometimes it keeps going on, and it's because something's coming into the system triggering the need for that consistent inflammation. That is in itself a process of active inference. Okay, things changing intrinsically. So these are the lipomyelin glycan layers. They are little hairy things that are hydrophilic. They don't like water. They bounce all the urine away, and their job is a little fronds to keep everything away from the mucin layer and the endothelium and the lamina propria and all the rest of it. The C fibres sit within here and a little bit lower down. So they shouldn't get, urine shouldn't get anywhere near them. But that can be broken down. So TRPV1 sensors are a type of purinergic receptor. It's in there for people that are interested, on the urothelium that gets stimulated when that urine gets through. They are normally protected, but urine gets through because the is a bit eczema-y, it's a bit broken down, and you get a big stimulation and that gets upregulated. The trigone at the bottom of the bladder has a lot more receptors than anywhere else at the top of the bladder, at the dome. That makes sense, because a lot of the time we only have fluid down the bottom, we don't have much. And you want to know more about it. Yeah, this is where you need to know more about things all the time. The problem is that in women, more than men, we tend to get recurrent urine infections, and we tend to affect this area more. So that trigone can get trigonitis, you can get a recurrent urinary tract infection postmenopausally, just keeps coming back, it's really irritated, and it's this area. You need to give it time to calm down, and then some of this urothelial issues will go away. Occasionally it doesn't catch up. Right, so at the top we've got happy bladder, all happy. At the bottom we've got little gaps in them. And this is a horrible potassium test, the K. So it's basically coming in, it's stimulating the C fibre afferents in this layer, and then you're getting pain, urgency and frequency, and you go, aha, you do have a problem. Which is a really mean test, and that's why they don't do it anymore.
Why would you get that deficiency in the gag layer?
Good question. They think it's due to a chronic inflammatory process. Well, they know it's due to a chronic inflammatory process, so it breaks down because it hasn't ever got the time to build back up again. The newest working hypothesis is that it's due to overactivity of allergy type response. Think about my nose at the moment, sneezing all week, yeah, and how horrible the broken down the skin around my nose, don't look too close, is. But that's because of a chronic inflammatory process. And so the inside of someone's bladder will become like the nose.
Is that three things that they're imbibing, they're drinking? Is it sort of just general?
The next bit's a bit more on why, but yeah, we don't know. It's going to be, and to be fair, it's going to be lots of different things in lots of different people. So it could be that they have a genetic predisposition. There is a Jew whose mother and sister also have BPS, and they're a twin who had it. Or it could be that they're also drinking things that are irritating the lining of the bladder already. That kind of thing. Hannes-Nielsen lesions, and there's the types of BPS that doctors like at the moment. They also call it non-Hannes IC, and Hannes IC. I know it's annoying. Basically, a urologist told me they're like bladder unicorns. You barely see them. They're quite rare. At the moment, they suggest that treating them improves pain. But I would say that to treat someone with Hannes lesion, you're going to have a consultation. They're going to do a cystoscopy and go, oh, I found some lesions. I found something that is causing you pain. When they do the cystoscopy, they anaesthetise you, they anaesthetise your urethra, they put in lots of anaesthetic into the bladder when they distend it. So you come round and everything feels better. And then they say, oh, we found the cause, so you feel better. Then they get you back in to do an ablation, and they do the same. But this time you've got a lovely nurse talking to you. You've got someone afterwards giving you a cup of tea and a biscuit. You've got a doctor saying, I've burnt all of the bad off you. And you've got lots of anaesthetic locally, changing your predictions immediately. There is no evidence that it changes pain over time. People that have cystoscopies and have Hannes lesions removed tend to do okay for a couple of months, 3 months, and then the pain returns. So what we need to do is give them physio, treat the rest of the system, play with their pelvic floor, treat everything else. And it's found in asymptomatics. Glomulations are also found in asymptomatics. So it is, we don't worry about that. We'll talk about it. So, heater sometimes gets a bit too hot. Yeah. Blue screen of death. Try this again. I think we're going to have to invest in a new laptop. It's done me well. To be fair, I think I pretty much have had this since 2015. Yeah. Just having an end of masters present to myself. Just a little paranoid that someone else will turn up. You said that they're not coming. Last minute. Some people just have more receptors in their bladder. So there is a subgroup of humans who have, about 30% of people who just have more purinergic receptors. So they're more likely to be a bit twitchy about their bladder. They're going to be more aware of it generally. As we get older, we start to increase the amount of acetylcholine we just randomly release in our bladder. What does acetylcholine do? God, it's in the back of your brain somewhere from physio. Yes. Makes things work. It's really, it's intrinsic in turning into ATP, causing your muscles to contract. So as we get older as women, we lose our estrogen. Older and women, we release more acetylcholine anyway. There is increased ATP released related to the increased ACH because acetylcholine turns into ATP. And we've already got more receptors, which means that older menopausal women get urgency. Okay, so that is a standard anyway that we can treat. But there are biological underlyers for that. There is ongoing research as to whether OAB or DO is a detrusor myogenic dysfunction of the bladder or it is to do with sensory issues to do with the purinergic receptors. Because you have more of them. And I want you to have that in the back of your mind. some people just get more issues. Oh, come on! Is it going to crash now? Let's do it the old school way. So, bladder lining, knowing this, alongside this, there's lots of different reasons why we have these funny symptoms at the bladder. We know that the afferent nerve activity is upregulated. Efferent nerves F off from the brain, that's how I remember, and afferents go to the brain. So stuff coming from the bladder to the brain is upregulated. They have a reduced threshold, so a change in their prediction. The prediction is that they're going to be needed more often, but they've got little going on. They have less of a rest period before they fire again. Persistent nociception in the area leads to a neuroinflammation, because if you do lots of nociception for a period of time, the actual nerves get inflamed. So they get white cells around them and funny fluid and stuff. Which in turn means the nerves get a bit hypoxic, the nervi majora. The blood supply to the nerves isn't so great. We've also, in this bladder afferent, all of this neurally stuff in the bladder, we also have a change in our spinal cord. So the spinal cord's crosstalk happens. Let me draw this. I always get that on there to make me draw it. But we don't have a board. Do we have a board, Lily?
There is one somewhere. I can check if it's
Just
in
stick
there.
it on the wall somewhere. Okay, I'll start drawing it. Yes. Oh, that was a bladder. Sorry. Stick it on a Okay. So, this is your dorsal horn. It's your spinal cord. Come on over here for a minute. Have a little wander. So this is a cross section of your spinal cord. If you remember within the dorsal horns, on the left and the right, you've got these lamina. You've got kind of 1, 2, 3, 4, 5, and it goes on, I think there's 8. And different nerves are meant to come in different places. So if you're a C fibre, you're meant to come in here, and synapse with one of the things that will whoosh up to the next level. If you're an A delta or an A beta, you're meant to come in here. And whoosh, different kinds of information. Okay? When you get lots and lots and lots of information coming in from C fibres, they start to sprout. What do you think happens then?
Who gets confused?
Yeah. So information coming in from a C fibre gets registered as information coming from an A delta or a beta fibre. So instead of having the kind of information we're meant to transmit here coming up, we've got that information clouding what the brain then considers, or the body considers as coming from an A beta or a delta. This is the only thing I'm going to tell you this weekend that we cannot change. Everything else we can change, we can reverse. But C fibre sprouting we can't change. What we can do with C fibre sprouting is down-regulate it, get it all to calm down so they don't listen to it so much, get much more other information coming in, get the system to calm down in total. But that is never going to change when you've got C fibre sprouting, you've always got it.
Is there any C fibres in the bladder?
Loads. That's the pyrenotic receptors sit on the end of the C fibres. So that's what happens. That's why they get upregulated at spinal. The reason the bladder is always on their mind. They literally cannot not think about it. Nerve growth factor is a chemical a bit like Ronseal. It does what it says on the tin. It is something that makes nerves grow, makes them sprout more. It is something that is released in the bladder, NGF is released lots when the bladder lining is stretched. So like with blown up balloon, it is a muscle. If we move our muscle really quickly, you're going to have Golgi tendon organs, muscle spindle fibres that go, whoa, careful. And I'm going to contract slightly so that I don't move my muscle and stretch it and damage it. Exactly the same happens in the bladder. If you fill the bladder up really quickly, it will twitch to slow it down. That twitch is caused by releases of NGF, which help to give more sensation, upregulate the nerve function so that ATP can be released to stop it. So it slows that train. There's lots more work going on about it. This is so interesting. Interestingly, NGF levels are really important in the bladder. I'm trying to work out why. In dry OAB, they're not that important, but in wet OAB, we've got high levels. In UTI, pre and post, there's a dramatic change. So when active things are going on at the bladder, there's high levels of NGF. ICBPS, tumour and UTI are all very high. So in our poor bladder pain patients, they've got nerve growth factor levels akin to bladder cancer. Really, really high levels, which means there's going to be a real big upregulation in what the nerves are doing and also how much they're growing and more of them. So instead of having one guy going, yeah, your bladder's a little bit full, you've got a whole Wembley Stadium full of reporters going, yeah, your bladder's a little bit full. It sounds a lot louder. So they get more information about it. OAB and BPS, there isn't any significant difference between them, apart from pain, from chemical points of view. They're both sensory upregulation disorders. So any bladder urgency is to do with sensory disorder. Give it a couple of weeks, then watch the webinar I gave this week, which will explain it in more detail. First things. But when we think about urgency, we've really got to be treating their sensory systems of their bladder, not worrying about the protrusors so much. You can also get infections, and that happens more in the trigone, so that bottom little bit of the bladder. And if you get any kind of chronic infections, so someone that's a bit postmenopausal, like you're going on about them, but they're classic, they don't have so much estrogen, they're getting more trigonitis, recurrent infections every 3, 4, 6 weeks. You need to calm down that trigone area, calm down the sensory receptors in that area before you can treat them. So they are someone that needs antibiotics, estrogen, and then come back and see me in 6 weeks. And then we're going to start more physio. Allow the urothelium to restore. You need the to come back. 6 weeks of no infection, calm system, no inflammation, should help. Okay, yeah, so UTI testing, if you want to do the CUTI course 50% off of Theory 2020, that code goes for everything and for your patients. So there's a patient course as well, which I'll tell you about later, that you can physios get. You can give your patients 50% off to do the course alongside you. It takes all of the talking away from you. It's designed to help my NHS friends, or those of anyone, so that they can learn about BPS, they can be doing stuff in the background, and you can crack on with the stuff that you need to do. But as I said, go back in the Facebook group and you'll find it for free. Right, there's also some potential sensitisation that happens around this area with other conditions. Dr. Melissa Farmer's really cool, and she did some research with rats. She got some brandy rats and she watched them have sex, and then she gave some of them Candida thrush, and then watched what happened. It took 3 bats of thrush for them to become sensitised at the vulva, not want to have sex, treated differently. And that makes sense. You get something once, you respond to it. You get something again, you register it quicker, you respond to it by producing your white cells of inflammation, you have your soldiers stationed there. After you've done it twice, in rapid succession, you're going to start stationing your soldiers there to deal with the threat, because it keeps coming. So the third time you're like, yeah, we're just going to keep soldiers there. So you get more inflammation, more sensitivity, because everything's upregulated all the time in preparation for a fight. Because the prediction has been changed, and they have updated the prediction given the new data. The updated prediction is there is going to be infection here regularly. So we're going to deal with it. But that means that everything becomes hypersensitive. If you have a bladder infection regularly as a child, or 3 thrush episodes a year as an adult, you're more likely to have bladder pain syndrome. So a lot of you would have seen patients, the women that come through, that have had lots of bladder infections as a kid. Mast cells are a whole deal. We tend to get a proliferation of mast cells in that type 3C bladder pain syndrome. That's the one that we don't really want to treat, apart from lifestyle, habit, stress relief, that kind of stuff. But we get normal mast cell productions in non-ulcerative BPS and the rest of it, basically. Okay. So that was the peripheral. This is the central stuff that goes on. So in summary, the stuff that happens at the bladder. The lining gets a bit broken down. The nerves go, wah! Get excited. And they get more of them. A stadium's worth of nerves. Everything goes on edge. More blood flow, lots of other stuff. I haven't talked about the pelvic floor, I should probably think about it more actually. We're going to talk about that now. Essentially, you get changes. We get changes to our motor, our sensory cortex, and our salience network, which is the bit of the brain that decides where you put your attention at any one moment. So I am totally not aware of my bladder right now. I'm aware of you guys. I'm not paying any interoceptive awareness. Can't feel my raging uterus. But we also get an emotional psychological effect. That's a beautiful study with Paris Gonzalez, one of my favourites, that says they did blood tests of people and they found that when they were stressed, when they stressed them and they gave them physical stress, I can't remember what they did, but they gave them like normal life stress, like saying that they had a parking ticket when they'd come to their session, and they tested the stress levels. They found, and they did samples of the bladder, they found more bladder inflammation when they were stressed. Physically have more going on in your bladder when you are stressed, which we knew. But we get these other changes, and this is the MAP research networks looking at it. What it comes down to is there are three little bits that control the bladder function. You've got a bit that says how full your bladder is, a bit that says how tight your pelvic floor is, and another bit that says how much attention to pay to it. And they get upregulated, which is beautiful, and which it explains why I'm going to spend the rest of tomorrow telling you that we need to touch the pelvic floor to change the bladder. Because what we do is we touch the pelvic floor and the bladder changes. That's why, because they are intrinsically linked in the continence network. Essentially, they're also intrinsically linked from a visceral neurology point of view. The motor cortex of people with BPS, this was urologic chronic pelvic pain syndrome, which is men, but it's BPS, looks exactly the same as people with fibromyalgia. The changes that occur. Because they're in a pain state. Isn't that interesting? Yeah. They don't necessarily get the fatigue, but they get the central changes akin that would suggest a chronic pain state. And then we get some limbic system changes. What does your limbic system do? Yeah. So when you're in pain for a long period of time, your brain's been paying lots of attention, salience network, doing lots of stuff, trying to manage the situation, keep on top of it, see what's happening, send down more reporters to work out what's going on. It can't keep doing that for long because you've got to be looking around the corner for other bears and other things that can be attacking you. So your brain needs to have more, it needs to delegate the responsibility for looking after your chronic pain state. So it gives it to the limbic system. So now our emotional centre becomes absolutely embedded with our pain state. If we have a crap day, our pain gets worse. If our pain gets worse, our mood decreases. They are one and the same, and that's why the patients that come to see us are unable to control their emotions. They're emotional about their pain state because it's intrinsically part of it. And that's why we're good at what we do, and what you do in clinic is awesome and wonderful because you sit down with women and you talk to them. And 80% of what we do is how we communicate with our women because you're helping their limbic system to calm down before we even think about doing anything via medical to them. One thing we've got to think about brain scans though, as my little caveat, is it's a bit like a bloke on a hill going, what's he doing? Is he signalling to his friends? Is he calling in the rescue helicopter? Is he doing some yoga? We don't know. We just can say that he's on a hill and his arm's in the air. So when you look at brain scans, you can just say there's more blood flow in this area. We can't say why. It's a little bit of a caveat on brainy stuff. There's still a lot of work going on in there. This should hopefully put like the cherry on top in understanding everything. We've got peripheral stuff, brainy changes that centrally mean that we're more likely to be in pain, more likely to experience pain about it, coping with it, that kind of stuff. We need help. It's all a circle. And then we also get some autonomic issues. In myofascial pelvic pain syndrome, which is the syndrome where when you touch the pelvic floor it hurts, which is not normal, we have autonomic issues. We have autonomic neuropathies. So a change in how the nerves are functioning within that muscle. What that means is that you get a sympathetic vascular dysfunction. So the blood vessels that go through the pelvic floor, because the pelvic floor is like this, because that centralised section says pay more attention to the bladder is more full than it feels it should be, and your pelvic floor needs to be tighter to support that whole area and protect it. At the same time, when the pelvic floor is like this, not much blood is getting through, and the blood that does get through, the vascular system isn't able to take fluid back into the system, so that pelvic floor gets boggy, fluidy, swollen, uncomfortable. The nerves that are within it aren't getting a good blood supply, so they get uncomfortable and oxidative stress. In bladder pain syndrome specifically, you also have a diminished vagal nerve function. What does the vagal nerve do? What do you think it is?
Heart stuff.
Yeah, heart stuff. It's the main nerve that goes between the brain and the viscera, all of our guts. And it's our main parasympathetic nerve, our rest and repose nerve. So if we've got poor tone, they call it tone dysfunction, on our vagal nerve, we're not getting much parasympathetic calming activity to our bladder or our pelvic floor. So we get a really unhappy, upregulated, boggy, tight, unhappy pelvic floor. And a small periaqueductal grey. Your PAG is the bit of the brain that is responsible for our descending inhibition. And you think if someone's got loads of chronic pain, they'd have a massive PAG, because it'd be working all the time. But that's the point, they don't. They have a very small one, smaller than it should be. Because if it was working all the time, they wouldn't be in pain. And all of this we can change. We can upregulate their periaqueductal grey, we can improve their descending pain inhibition. You're all looking very blank. I promise it'll make more sense tomorrow. And we've got loads of visceral overflow. So if this is a sensory overflow, if you have something in the vagina, you can also feel it at the uterus. There should be more areas in here. The bladder, you also feel at the perineum and the suprapubic area. And this is about visceral and somatic nociceptors. So there's a huge crossover. A lot of patients you'll know that have IBS will get kind of funny pains, or they might get a constipation and it'll hurt, and then they'll be urgent in their bladder as well. It's not just about the pressure in the area, the physiological pressure, it's about the sensory neurons, sensory nerves, and all of the neural activity and the nociception activity that is crossed and stored. Okay, whack-a-mole, stand up. Anything. Tell me anything. Go on, Maggie, you want to look like you want to go. I'll let you breathe.
We have peripheral and central facts.
Brilliant, sit down. Stuff goes on here, stuff goes on here.
I've got that. If we've got pain in the bladder, it can be a swelling in the colon, for example.
Absolutely. This will crossover.
Lots of C fibres firing off can affect the other nerve fibres.
Perfect. Upregulation of C5 afferents in your neurologic.
The limbic system is connected to the nociceptive system running on the limbics.
Yeah. So your emotional centre controls your perception and your experience of pain.
Increased acetylcholine with age.
Amazing.
Some people have more common receptors in the bladder than others.
How's it? Okay. Yeah, sit down. Good job.
Your blood gets more sort of
Infected. Yeah. Infected, unhappy. Yeah. It's because they're like little hairs. Little hairs.
The acetylcholine is linked with that bladder urgency.
Perfect. Sit down. Ignore acetylcholine. Okay. The why is a lot quicker. We don't know. There's a genetic panic connection. So if you have panic disorders, you are more likely to have BPS. So it suggests psychosocial, a true brain issue. If you're a monozygotic twin, so you've got an identical twin, you're more likely to have it if they've got it. And you're more likely to get it if you've got 3 non-bladder syndromes, which are these things. They're complicated. I made it a bit easier. Chronic pelvic pain, depression, migraine, and allergy are the most likely ones. But you've also got IBS, fibromyalgia, chronic fatigue, panic, Sika, which is Sjögren's syndrome, asthma, and vulvodynia. You only have to have 3, and it doesn't matter what 3. Can you think of anything that would connect all of these conditions? What connects allergy, depression? It's a hard one. and it depends on what you read in. Okay, it is a difficult one because they don't look like from the outside they are, but they're all autonomic conditions. They all have a huge basis in the autonomic function and dysfunction. So we think it's a potential that BPS is part of this underlying autonomic dysfunction in some people. And in some people, this is just some of them, they will present, this is Chilimsky's data from 2017 in Washington, and Clemens, I think they've got updated it. They studied people over a period of time and found they started off with like migraines and depression or panic attacks. Over time they developed ICBPS. It's called ICBPS, by the way, I forgot to say at the moment, as a mesh term only. Who's done any masters or postgrad? Mesh terms then. When you do research and you put in your words to search for them, they're called mesh terms. We are moving from interstitial cystitis, IC being the term, and we're moving to BPS being the term. So in the interim we call it IC/BPS to catch everyone, so we don't miss anyone in the Far East that writes about IC, because we want to know about it. So hopefully in the next 5 years it will translate back over. Anyway, so they get these things, they end up with fibromyalgia, chronic fatigue. And the same from Chilimsky's data, it's the same vague progression. It doesn't mean that you will get it, it just means these are commonly found often. So it's more likely, which suggests an underlying autonomic issue that we can work with. It increases your risk, but it doesn't predict disease. You can have allergies, depression, and low back pain, but not get bladder pain syndrome. You just live with those things. It doesn't mean over your lifespan you're going to get worse. It's just more likely in some people. And it doesn't matter what you get, just that you have to have 3 of them. So there's a central commonality to your dysfunction, and it's non-uniform. Okay, stickers. Saturdays, aha, cup of tea. And biscuits, and grapes, and raisins and nuts, and no oranges, although there are some. We've got to hide the oranges. Somebody doesn't have oranges, we're just not going to have the oranges. The rest of us love the oranges. Okay, you can move. Great, cocktail.